I'm actually really looking forward to our next panel, which is Innovative Models in Emergency Medical Services. And I'd like to introduce Dr. Dave Duncan. Obviously, a lot of experience. Dave is an emergency physician. And I would probably say most recently through the pandemic, one of the most important people here in the state. When our hospitals were challenged, I know I heard Carmela sharing some of this last night, Dave was the person who made a lot of things happen. So, we're really pleased to have an expert here to lead our discussion as we talk about innovative models in emergency medicine. So, Dave, if I can turn it over to you, please.
Number one, don't spill your water on the microphone. Good morning, everybody. Thanks for coming. Thanks for listening. And thanks for taking that break so you don't continue to fall asleep and drool on your tables while I'm up here talking. What a challenge. I was in a good mood until I listened to Carmela's, first hour. I mean, not only current state of affairs, but also the PTSD and chest pain that it kind of brought back. Do you have a nitro? Yeah. I'm going to spend some time and just try and hit high points and stay at 30,000 feet to hit on some of the pieces that we all participated in through COVID. We were among the most innovative states. We also performed among the best from all states. I had the privilege of having first access to a lot of that data that would float through and compare California to other states like Florida, Texas, Pennsylvania, pointedly looking at outcomes and mortalities and all these things, because this will surprise you, there was a lot of competition out there. I know. Who would have thought? I'm going to start with a couple of quick points, and then we're going to do an introduction here. I just want to set the stage on what a challenge and what a dichotomy to try and create a way to move the barge, as Carmela was saying, in a fashion that allows you to respond. So here we are, we're all part of bureaucracies in some way, shape, or form. And suddenly this thing is upon us, this pandemic that we may or may not have been planning for. And now we're asked to turn that barge, 180, maybe 360, and move it along in a way that allows us to respond rapidly. And I found myself in this job just 2 months before it hit. I wanted to make sure that COVID was actually blooming in Wuhan before I signed on, and then I took the job. But that said, I found myself using these words frequently, which are, I'm from the government and I'm here to help. No, really, I want to help. So trying to get through the headlong diversity between getting all these agencies to work together that are so used to not working together, I think was one of the biggest challenges. Maybe that's the 60,000 foot challenge that we all hit first. And then we had to march through and figure out ways to work together, which we did phenomenally well in California. So I want to hit on some of those, but first I want to introduce our panelists if I can. And I think we're going to go in this order if we haven't talked about it, but I think, Adam, I'm going to go to you first, and then Harris, and then Justin. Thank you, gents. I don't know that I want to do these introductions. I'm going to do something really brief. I've kind of known Adam peripherally from my EMS history. He's been a leader at REMSA, a nationwide renowned EMS system in Reno. He also heads up and is responsible for their strategic advancement and innovative care projects. And although we didn't cross paths too much with Reno, we did do a number of projects together, and his innovations were also borrowed for some of the California projects we had in mind. So thanks for that. Next, Harris Koenig, I'd like to talk about briefly, if I can. We got to know each other far too well on what maybe started out as adversarial calls, talking to counties and states and hospitals, and they shortly after, I think, became collaborative and communicative, and really an amazing work in San Bernardino and Riverside. Harris put together some of the most impressive data dashboards I saw early on, and was an innovator in those 2 counties that got impaled like so many others. So Harris, thanks for your work there. Justin, I've just met in the last couple days. Pleasure. Justin is a data guru for CHA, and he's going to share with us some high-level data that we're going to focus on, and I think predominantly centering around an area near and dear to all of our hearts, and that's ambulance patient offload time, or APOT data, as one of the pieces. I want to end with him just so we have something to talk about, you know. Anyway, with that, Adam, I'm going to hand you the mic. Let you dive in first. Thank you, sir.
So good morning. Thank you for the opportunity. My name's Adam Hines. As he said, I'm the executive director at REMSA Health. And, you know, there are many reasons probably why we are here. And for those of you in the EMS circuit, there's a gentleman named Dr. Corey Slovis, and he talks in 5s. There's 5 things to everything: saving people's lives, people dying, everything. So there are really 5 things, and it comes down to the 5 Ps, which are patients, providers, physicians, payers, and then there are politics. You know, for 40 years in EMS, we have told people, call 911. It's the easy button. Whether you have somebody stuck in a tree, whether you're having a heart attack. And so we've done a great job of that into our communities, and that's really part of the reason and part of the driver that we're seeing here. I'll tell you, for my organization, we run about 90,000 calls. We're the exclusive provider of EMS services for Northern Nevada, for 911 and interfacility transfer. And despite the fact that we are seeing an increase of call volume, 7%, just continually compounding, this was not actually an issue in our state for a long time. But I will tell you that in September of 2021, when COVID hit, when staffing was low, when patients were looking to EMS to solve all of their problems, we had to come up with a solution. And 40% of our units that we're transporting to our local hospitals, and I only have 6, and so, you know, this community and the counties in which are represented here have probably a different makeup, but of the 6 hospitals, 40% of my units were experiencing an offload delay, and that definition is something in which a unit would encounter greater than 10 minutes from transition of care. In addition, I know one of the pushes is, and probably not necessarily very popular, is we know this is not just a hospital issue. It's a lot of the times pushed as this is a hospital issue, but I'm on the board of directors for the National Registry. I'm on the Council for Standards for the American Ambulance Association. I will tell you, this is a national conversation that is occurring. And one of the things that people think is just get a statute. Hospitals, take our patients. The state of Nevada has that statute, and it's been there for a while. 30 minutes of arrival, they will accept the patients. And I'll tell you, we never really did that. We didn't have that problem, and in 2021, we were put in a position, should we look to do that? In addition, we had policies that said we will close hospitals, which complicated the position that we were in even further. And I'll kind of give you an example. With 6 hospitals, if ambulances are experiencing a delay and we close a hospital, that requires volume to go to other hospitals, which puts them in positions where they become inundated, and we have no choice but then to close them. And then we only have 1 hospital open in the community that's accepting ambulances. It's less than ideal, and it doesn't fix the problem. And so what does fix the problem is having conversations. Obviously, there's an interest with all of you here at working to strategically and appropriately fix this problem that is endemic. I mean, if you look in the headlines, a lot of the times you're seeing ambulances are waiting 8 hours, 9 hours, 10 hours, which is not the best use of resources and not what you want either. And so, despite the fact that there may be systems in place, and when I had a conversation with our colleagues, a lot of the stuff in which we have done to try and reduce this, again, 40% of our units were being consumed with offload delays greater than 10 minutes. We put waiting room criteria that says if you're fit to sit, we're going to put you in there. And that included, obviously, having IVs and maybe 1 dose of narcotic or antiemetics. In addition, you know, in EMS, we love colors. In the hospital system, we like priorities of 1, 2, and 3. And so how can we merge different ways in which we triage patients so that you're going to see them in a certain fashion, and having those conversations collaboratively? When we decided that this was a problem and endemic in our community, we met every single day. Every executive of every health system, every fire service, every EMS officer that was on met every day, and we talked about performance. And I know that we're going to talk about data here in a minute, but data is king for us to understand where we are and where we're going. Being able to have those conversations and decide, okay, how are we going to accept some of these patients? And this was a temporary way. This is back in COVID when there were tents, and we had to decide a systematic way of how we were going to accept patients, and merging the ESI triage criteria, which is very familiar to our healthcare partners, and then also taking some of the triage criteria in which, you know, in EMS we live by many times with the red, yellow, and green, and being able to have an understanding and adopt a way in which we can accept patients within a certain time frame. We're going to see red patients immediately, we're going to see yellow patients within 15 minutes of arrival, and we're going to see green patients at 30 minutes of arrival. Again, that allowed for us to expect and have understanding and a set of rules of engagement that would allow for us to properly care for patients. In addition, the nurse health line, you know, so we're very blessed to have a nurse health line. Nurse health lines are very expensive, and a lot of the times to have that infrastructure. And we have great partners that are located here within the community that we work with to provide access to a nurse health line. But we know that 60% in my community, 60% of the people that are calling 911 receive little to no care, or care that could be provided at first aid level. And so we have to work to change that. But a nurse health line is one way systematically through a dispatch system that you can safely triage patients out of the 911 system. And in our community, out of 82,000 calls, 6.5% of them are eligible based on what our medical directors have approved, with nearly about 25% of them being transferred over to a nurse. Part of the reason why we can't capitalize on the majority of that is nurse availability, or other reasons like the patient declining. But I think important, and this is where politics and sometimes some of the other things come into play, is when somebody calls 911, there is a expectation that they're experiencing an emergency, and we know that that's not always the case. And if they are experiencing emergencies, our nurses are very skilled in that safety net to identify and get them back to EMS. 97% of patients that go over to nurse health line that are triaged through some sort of algorithmic triage system like medical priority dispatch are safe to do so and get where they need to go. Another barrier is transportation. I will tell you, I sign requisitions for taxi cab vouchers or Uber Health each month to facilitate transportation of patients with low acuity emergencies. Less money than it takes for me to send one ambulance to one call for that month. And so it's money worth spent at doing that. Daily performance, having conversations and access to the data. This is one example of something, and you actually, and I don't work for First Watch, this is not necessarily, there's no conflict of interest, but First Watch is a partner in San Diego, is a partner of ours that provides dashboards and access to real-time information that's being sent. This goes to hospital executives every day to let them understand what the performance of their hospital is. This is the number of delays and the time in which the delay occurred. And you know, we had to have an uncomfortable conversation because a lot of the times everybody wants to hide under blinded data, but that doesn't necessarily drive performance. And so in our community, the data's open, the data's shared, the data's unblinded. And that really helped one of our largest health systems, which had the highest number of offload delays, really perform. We also know that EMS owns part of that, and we know there are problems with throughput and there are problems with transferring patients out, and so we have to be a good partner at making sure that that patient on the medical NEF floor that needs to go to skilled nursing is moved so that ICU step down can push up, so that ICU can push up, and our partners in the emergency room can offload patients so we can accept those in the emergency department. And so this is an example of a live dashboard we send and we share and have transparent as to understanding what our performance is and increase that. And then, as you could expect, it's about just understanding the performance. What does the hospital, what is their performance compared to others? What is the percentage of times in which, based on the transports, are you going to encounter a delay? And this is just kind of run-of-the-mill type things, but again, data is king. The data is what's going to drive us. And then what is also important as healthcare executives is what is our market share? What is the patient population that is being diverted from our hospital if we are unable to? And I will tell you, in our community, this was probably one of the #1 drivers, is when you begin to see, because there are offload delays here and we have to shunt patients over here, the impact to the patients in which you would serve was extremely important, and this is an example of that dashboard. Before I wrap up, I just want to share with you that, so we went from 40% of ambulances experiencing an offload delay in 2021 to pretty much 2% the last couple months, and on average for the last 8 months it's been under 5%. A lot of that is a work of our health system partners. A lot of that is because of conversations and constructive strategies, but we also need our patients' help doing this, and it's our job to educate them that 911 is for emergencies, and the 911 call's changing, and we don't expect them to have the answer because they are not medically trained, but we do need to use strategies such as triaging patients, assess and refer for paramedics to be able to refer people to clinics, having access to transportation because that's the barrier, nurse health lines to safely triage patients, and then continuously educating so that we can reduce the reliance and utilization of 911. And so those were the strategies in which at least our community used to try and get to where we are, which in my opinion from 40% with a compounding increase in the number of transports of 7% over the last couple years has been successful and has increased unit availability. So thank you for the opportunity.
That's phenomenal work, Adam. Thanks for sharing that. There are so many spokes in this wheel. All the pressure seems to funnel right into the hospital, as we all know, and particularly into the emergency department. And just to sort of draw a nexus for what we all experienced in the last 2 or 3 years, one thing became apparent is the hospitals are the end-all, be-all for delivering care. We tried to do other things. We set up alternate care sites. We tried to leverage alternate destinations. We did lots of things, but at the end of the day, what we all discovered, unfortunately for many of you, is hospitals offered the best economies of scale. If we could invest in the hospitals with more space, more staff, more stuff, we could take care of a whole lot more patients. All the ancillary services are there. We just needed to help. We all together needed to help build what you already had in place rather than, build new systems. But what happens there is, in one degree, that reinforces that hospitals can do it all. You are the end-all, be-all, and yeah, they can handle whatever we send to them. But we do need to redesign. We do need to look at every spoke in the wheel, as Adam has pointed out, and I got actually some new ideas, thanks for that. Some new spokes in the wheel. I mean, educating our public is something we do, but probably not enough. I think that's a huge piece. Thanks for sharing that. The other huge piece, and so I talked about a lot of negatives in COVID. A lot of huge positives came to us in COVID as well. That includes, and I hinted at this earlier, the ability to communicate, collaborate, having, for instance, state government talk to county and to hospitals. The state, that's the entity that disciplines and finds us. I'm not going to talk to you, and I'm certainly not going to share more data with you. But here we are in a place where we all needed to figure out a way to share data, to share that data in a way that it's actively usable, not exactly real time, but we need the data. We need to be able to act on the data, and we need to see if it makes a difference. Is it valuable data? So those are all pieces that came to bear. Those are all things that maybe we wanted, but now it's been thrust upon us that these are things that we're absolutely going to require. And out of all that data that we were impaled with day in, day out, some data points became particularly valuable to all of us. I know for me at the state, I got all the data that you guys unfortunately had to, in analog fashion, fill out and spend hours every day and then send to us, and we had to figure out, what to do with it. But the data points that became the most valuable, there's probably a handful of them, and I'll, tell you, we took a handful of that data and we made a score out of it that helped us get some idea as to which hospitals were doing the most poorly. But probably the single most important data point that I would look at daily, I called it the vital sign of our healthcare delivery system, was APOT. And the reason for that is I called that where, the hospital meets the road, right? I mean, yeah, hospital care backs up into the ED care backs up into the EMS system, and that one data point ends up sort of giving us, a temperature. It's not the end all be all, of course, but it was at least something to track. And since we've discovered another, 30 data points, I'm going to go to Harris here in 10 seconds. He's going to tell you what he's done, and he's going to tell you what he'd like to do. And the data that you were able to bring forward to us, Harris, I think was invaluable and helped us try and create actionable response in real time. I know he's not a huge fan of real-time data. I am, so I'm just going to set this up for interesting discussion. Thank you, Harris.
Thank you. Yeah, it was a pleasure meeting Dr. Duncan on our calls. As you all probably did, we had oftentimes at least 3 times a week calls trying to figure out what the world looked like and how we might respond. I had the privilege of being the hospital liaison to the San Bernardino County COVID response team. After I had left my CEO post, I'm a recovering hospital CEO, and hopefully brought some value to that response effort. I was quite grateful to Dr. Duncan and whoever else at the state came into this idea that they wanted to kind of join our calls, because those calls continue now. We're every other week. And to have state leaders on those calls, and the calls now we're transitioning to RSV and flu and COVID and those kinds of things. To have state officials on and hear directly from county public health leaders and CEOs who are on the calls about what we were facing was absolutely critical. And they took things, and I saw things change because of their participation in those calls. And having that collaboration was quite important as you all tackled that. I was an old guy in the grandstands kind of watching the thing, but for you all who are on the ground doing the actual work, to see things actually change based on that conversation was very important. I'm going to walk you through kind of my personal journey in EMS, and it's going to actually intersect with Adam in that thing. But 15 years ago, I started getting an interest in what was going on in my ED. Many people don't have the appreciation that we do, that somewhere between 60 and 90% of the admissions to our hospitals, depending upon where you are and how you're organized and what your focus are, comes through the ED. The people upstairs, that's a proportion of folks coming in your ED. So I said, you know what, I'm going to start looking at this. So I spent some time, we made dashboards and pulled people together, and I got really immersed in what ED throughput was and what hospital throughput meant in that context. And as we all know, it's quite a complex set of issues that come into play when we're dealing with the throughput of EDs and hospitals. Later, I found myself representing hospitals on the local EMSA in our counties, Riverside, San Bernardino County, that's ISMA. I was the hospital representative on the advisory committee there, and got an appreciation for some of the political sausage making that occurs at that forum. And it was at a time, and it seems to ebb and flow, was at one of those times when hospitals were center stage with the lights on saying, APOD, APOD, it's your fault, do something about it, we're gonna fine you, we're gonna penalize you. So I was in the midst of that. And near the end of that period of time when I was in that role, there was a group of leaders that got convened that included folks from ISMA, from County Fire, from AMR, the transport agency or provider, Kaiser, IEHP, Inland Empire Health Plan, which covers 1 out of every 3 lives, is the managed Medi-Cal plan in our area. And we were going to talk about a process that was as far away from the hospital doors as you could think about, the 911 dispatch center. And one of the folks in that collective had information about the work that was being done in Reno and said, you know what, the one big way to start to impact APOD is to try to get people to the right care at the right time and not have that stuff all flow through the very expensive transport system and into a very expensive environment, the hospital ED. And the insurers were pushing this and had an interest in it because they wanted to save costs. They wanted to provide good care, but they also wanted to have good costs. Get people to the right care at the right time, and in so doing, avoid the cost of jumping into an ambulance and going to the most expensive place to receive care, hospital, emergency room. As Adam mentioned, some of the studies indicate as high as 50% of, and I think you said 60%, Adam, of the folks that are getting into the EMS system don't need to be in that continuum. I call that, by the way, response, transport, and treatment, RTT. You'll hear me get that because it's too many words to say, but response, transport, treatment continuum, right? So my colleagues, I'm a hospital CEO, I'm worried about business. What, you're gonna take 50% of my ER volume away? No, that's not what we're talking about. But there are a lot of people in here that don't need to be in that environment. And so that was important. And that conversation that happened now 6 or 7 years, well, 6 or 7 years elapsed from that conversation to when copying what had been done in Reno, we launched the emergency communications nurse system in San Bernardino County, and ESINS, ECNS, 911 call nurse triage system to start to move demand out of the system and get people to the right care in the right amount of time. And we couldn't have done it without the support of Reno, who provides on a contractual basis coverage for that line as we've been moving and implementing this program. We've struggled because as soon as we opened, COVID hit and staffing problems and all those kinds of things. So we're operating at about 40% of capacity or 30% of capacity now. But the early results are showing it'll save insurance companies millions of dollars. The contribution margin to the insurance companies is huge, and they're the potential ultimate funding source of this effort once we move along. Then COVID hit. Hospitals and EDs were overwhelmed. Response and treatment providers were overwhelmed, not only by the volume, but we also started to really understand, and I think that the response and transport folks got a much better understanding that if hospitals can't move patients into skilled nursing facilities, they can't take care of their ERs. Because if you can't get them to the skilled nursing facilities, the med-surg beds back up, the ICU beds back up, and the ambulances line up in the backyard, right? So I think other segments of the RTT system started to get a sense for the fact that there actually are capacity constraints and other factors in play that impact a hospital's ability to respond to APOD. I might mention this, which you all know, but many people don't, that only 20% of a hospital's volume is coming in through the ambulance, 80% of it's walking into the other door, right? And so there are tremendous burdens that are placed on hospitals in that respect. So hospitals were back again in the limelight. APOD and hospitals were in the limelight, center stage with the lights on. It's APOD, it's your fault, you have to be penalized. If we don't penalize hospitals, they're not going to change their behaviors, and we went down this penalized, discussion, which is ongoing, by the way. So we looked at we did some research, looked at some studies. I reacquainted myself with a study that CHA had authored in 2014 along with CalEMSA, talking about a toolkit to address APOD. I reviewed Dr. Duncan's report to the state legislature on APOD, and both of these studies that were done 6 years apart had some similar conclusions. One was that the issue is complex, no kidding. That APOT was only one metric in this to measure the performance of this whole ecosystem, right? That certainly didn't make sense. And that in order to address APOD and ED overcrowded, you needed participation and buy-in from RTT system leaders and a commitment to a long-term performance improvement process. In February of 2021, in San Bernardino County, we formed the RTT Executive Group, Response, Transport, and Treatment Executive Group. It was formed in this way. We looked at the county CAO and the lines of direct authority that the CAO had. We looked at those areas where they had indirect control through joint powers agreements. For example, the CON-FIRE is a consolidated fire agency with multiple fire agencies under one roof. They handle 80% of the 911 calls in the county. IEHP, the Medi-Cal Managed Care Plan, ensuring 1 out of every 3 lives in our area. JPA with the county, right? It's a public plan. And so we pulled together those folks that were in that sphere of influence or authority, the CAO's office, and we added a hospital representative, which is the Inland Empire chairman of that group. We actually have 3 hospital representatives on the group when you really look at it and sift through it. There's the HASD representative, there's the county hospital CEO, and their emergency medical services medical director. The purpose of this group, when you sit there and as I present this, and I've got to call at 1 o'clock on this, the presentation or the purpose of this thing is not to have the county go and set policy. That's not what we're doing. The purpose is to pull together all segments of the RTT system and put people in one room and have a place to have conversation and to have creative thought that might result and stimulate change. It's not to have a top-down approach, it's to have a conversation. And so we're still dealing with this because we're in the early stages that people are fearful that it's a policy thing. Oh, we're going to go set policy. It's not about policy, it's about conversation. We needed a unifying purpose and a compelling goal to pull these people together. And the compelling goal was we want to better serve 911 callers. Everybody in that continuum has that as a goal. From the fire guys that are coming down the pole, putting their boots and getting in the rigs, to the transport people that are trying to respond quickly and get the people from the scene to the hospital, and certainly the hospital EDs so they could provide appropriate care and treatment. Everybody has a stake in it across the continuum, and if we keep our eye on the patient, which is hospital CEOs and leaders, we do all the time, if we keep our eye on the patient and not our personal interests, we can actually make progress in this respect. There's some guiding principles in the initial work that we're doing. Each leader had to agree and commit and be engaged to this long-term PI process. Decisions and improvement activities were to be data-driven, and trust will be built through data and information transparency. An initial action plan was adopted that had each segment, response, transport, and treatment. We had an action plan for each of them. Principally, initially, was to, hey, we need your data and information, and we're going to put together a deck so we can understand some aspects of this continuum. In the response area, our main focus, since we had already had an investment and started dealing with the ESIN's program, 911 nurse triage, was to support that and try to get it up and running as much as possible. Which in the response area, since fire is running the dispatch, is make sure that the dispatch guys are giving an EMD code for the callers, and that the patients who are qualified to move to the nurse triage function actually get to that. So there was accountability on response, right? Not the 2 minutes and 15 seconds it took them to get up out of bed, go down the pole, put their boots on, and get in the rig, but how are we going to impact the system by trying to take volume out of the system? As to the transport, there was a lot of, what's the right word? There were many questions about the performance of the transport function under their contractual arrangements with the county. And so we wanted to kind of get some transparency by the hospitals and by the response folks, principally fire, to understand what was going on in that arrangement. So that was a focus for them. And for hospitals, since most of the time that's in that RTT spectrum is sitting in hospitals with APOD, obviously we needed to look at hospitals, and we needed to start providing real-time accountability for hospitals. We did it a little differently than Adam did. We created one metric. The one metric was, what's the percent of delayed rigs at any given period? So the number of delayed rigs divided by the total number of rigs gave you a percentage, and I'm encouraged to hear that 3%'s been achieved, 2% in Reno, and I'll have this digression for a moment. When I was looking at the data, and it speaks to the work not only to your colleagues in San Bernardino County, but I'm sure you all did as well. When I looked at that data point for 2019, 2020, and 2021, it was 40% in all 3 years. I want you to think about that for a second, because 2021 was the height of COVID. And hospitals in our county kept bed delay at 40%, which is not good at all. It should be close to zero. But they kept it at 40%, which means hospitals were doing what we all know they were doing. They were busting their butt to take care of as many people as they could. So hats off to the colleagues in the community. So that's the metric we're using, not minutes, because minutes has its own problems, and if somebody wants to ask about that, I can talk about it. We've achieved the following, just to wrap up. We're getting cooperation for people to provide data, which heretofore has been siloed or tightly held so nobody could see what was going on. Fire was reporting stuff up the fire chain, transport was reporting up to ISOMA, the hospital guys' data was finding its way on the front pages, but nobody was sitting there trying to pull the data together to understand. So my call at 1 o'clock today is with the fire guys to get one aspect of their data so we can continue this work of assembling this deck for this RTT executive group. We've developed a handful of RTT system performance metric graphics that in this first part of this deck. For the first time last week, we have a chart that shows the performance in time, the timeline for RTT across several months. So everybody can see what the response times were from the time the call came in till the time arrived on the scene. They could see from the time that the patient, with whoever responded first was on the scene, to treat it and hand it off to the transport provider. We can see the transport to the hospital. We can see bed delay, and we can see when that rig got back into service for the first time. It'll be presented to the committee, and we have that back 6 or 8 months now. We're going to be looking at some dashboards to compare data across segments of RTT. For example, what is transport rig deployment? What's the impact of transport rig deployment on APOD, on bed delay? We're looking at data in this deck to provide a deeper understanding of possible causal factors, ICU bed capacity versus bed delay. So we can start looking at some of those things. And when I say looking at them, for many of you in the room, you know what that answer is, right? But for the transport and response folks, maybe they don't have quite an appreciation for the hospital's capacity issues when we're trying to process people. We have commitments to stabilize and maximize the 911, the impact of the 911 nurse triage program. We have commitments to do that. I'm hoping we'll be able to do that. Everyone across the continuum is faced with staffing challenges, and that's an issue. Finally, most important, strike that, in tying on to the last conversation, Megan, I saw Megan here, the HASD representative, work with the Department of Behavioral Health in the tail end of COVID to start to get a mental health ED patient registry. That is now launched, and we're now collecting data, creating a registry so we know the patients, what they came to the ED for, what their length of stay in the ED was, and about 17 data points that we're going to be able to understand the impact of mental health on EDs and try to figure out ways for mental health, Department of Behavioral Health to either strengthen existing programs or create new programs to respond to those needs. And finally, most important, RTT leaders are sitting in the same virtual room, calmly discussing. We joked about it when we were getting ready to ramp it up. You need to leave your knives and guns at the door, right? We want you all to come in and play nice in this space. They are playing nice in this space. We are having conversation for the first time across the segments. And it is encouraging, and I hear from the members of that group, it's encouraging that that conversation is happening, because everyone now is being able to talk to each other, and you'd be surprised there's commonality of problems, at least with staffing at the current moment, across all segments that are being challenged. So people are getting an appreciation of that. We're really early in this journey, and I'm hopeful that we can continue to make progress. Everybody, as I said, is guardedly optimistic that this effort will result in some needed change in this system. Thank you very much. Appreciate it.
So well said and described. Thank you, Harris. And I got to watch him do a lot of that. To reiterate, I think the 30,000-foot point that he makes so strongly, that's probably among the most important. If we can leverage communication and transparency to try and create collaboration, cooperation, and implementation, that's where this all starts. But maybe secondarily important, or among the most important, is this data piece that we've touched on, and I want to get into that in hopefully adequate time frames here. Let's bring Justin up. Thanks.
So let me just start by saying I'm very thrilled to be speaking with you. Former life, I was a registered nurse, and I remember very clearly my first student nurse clinical rotation was in an ED. So it wasn't a nurse yet, I was still a student. And I was paired with a preceptor, an emergency department in an academic medical center, a very busy one in Northern Virginia. And after watching how hard she worked for 13, 14 hours, after watching how hard all the staff, physicians, EMS personnel, everyone worked for 13, 14 hours, I decided after that first clinical shift that I was going to, that first student clinical rotation, that I was going to quit. My mom, who's a registered nurse, talked me out of it, wouldn't allow it. A couple professors who weighed in as well stuck with it, which I'm very glad I did. But reason I went there and wanted to say that first is just to say a big thank you to all of you, a high level of respect and gratitude that each of you and your staffs are working every day in an atmosphere that's so intense that when someone who's not familiar with it walks in, it makes them immediately reevaluate their life plan. So really want to thank you all and understand how hard it is that all of you are working on this. Much appreciation for that. So what I want to provide right now is going to be a lot of overlap with what you've heard already, but just want to provide at a state level, at the 10,000-foot view, what are some of the conditions, what are some of the prerequisites that need to be in place for APOT improvement? Realize, I want to throw this caveat out there that every LEMS is different, every city is different. A lot of communities are already embracing some of these interventions and actions, and in those cases, some of the things I'm talking about will be maybe not as appropriate because they're already in place, others not as much. But that said, just really wanted to start with a high-level level set and begin with, like I said, those action items that are needed. So, getting into it, what are some of the prerequisites for reduction? First, we need consistent data collection. We'll talk about that more in a moment. Second, we need root cause analysis to identify bottlenecks. To be clear, realize that hospitals are doing a lot of work already to look at their own data and understand where the bottlenecks, where the throughput sticking points are within their facilities. What I'm referring to here is really at the broad view, at the community level. What are some of the bottlenecks there when we're talking about the entire healthcare community, talking about all personnel in the healthcare system? What are some of the spots where we could do better, and what are some of the throughput issues on that level? Tip of the cap to Harris and some of the work he's doing. It sounds like they're already starting to drill down on that. Questions like, do we even have enough ambulances on the road? Are they fulfilling their contractual obligations? Do we have enough community mental health providers? Things like that are going to go a long way to help solve the problem. We need a broad behavioral change. Definitely need a public education campaign on the proper use of 911. We'll delve into that in a moment as well. Reliable and coordinated statewide surge planning. The operative word here is statewide. Realize that historically and up until now, there have been some very detailed, very robust surge plans that have been formed at the county and LEMSA and city level. But as we learned from COVID and now are learning again with RSV and again with flu, respiratory viruses aren't local, right? We now are in a new era where we have statewide emergencies, statewide surges, and we need to have a statewide plan that ties a thread through all those local surge plans to make sure we're moving resources appropriately. As Dr. Duncan pointed out, that work started in earnest 2.5 years ago, and it continues to this day, and more work needs to be done. We need offload time goals that are flexible. One 20-minute standard inflexible goal time imposed statewide is not going to be particularly helpful. We need goal times, not to say we don't need goal times, but we need goal times that are reflective of the variability in each of the community, each community, excuse me. Every hospital is different. Different hospitals serve different populations, different hospitals have different capabilities, and each goal time needs to be reflective of those differences. Those goal times also need to be reflective of the differences that exist in policies in different LEMSs. So in some LEMSs, for example, diversion is allowed. In others, it's not, and we need to allow for the APOT picture that's going to be painted by hospitals where diversion is allowed is going to be substantively different than those communities where diversion is not allowed. And then finally, we could benefit from an updated toolkit that reflects the clinical practices and lessons learned from COVID. That toolkit, as alluded to earlier, was formed in 2014. Again, obviously, a lot has been learned since then. So, the importance of consistent data. On the surface, it would feel like APOT is something that's pretty easy to measure, right? Because we're just talking fundamentally about 2 data points. When does the ambulance arrive? When is the patient dropped off? That said, when we speak to hospital leaders and we have them audit their data as it's presented to LEMSA, which doesn't often happen right now, there's not a consistent format or process by which hospitals can audit or review their LEMSA data. But when we ask them to do that comparison, a lot of times it's great. However, not insignificant number of times, we hear that there's some problems with the data. Reasons for that abound. In some cases, it seems to really focus on patients on either end of the acuity spectrum. We hear sometimes about the ESI-1s who come straight to a trauma bay and that transfer of care button doesn't get hit when it should. The transfer of care is a little bit fuzzy in those circumstances. On the flip side, those 5s that go straight into a waiting room when that's allowed, sometimes there as well, the transfer of care can be a little bit fuzzy. And then there's a host of other reasons. The software tools, image trend, things like this certainly go a long way. But even with those in place, there's still a degree of data cleanup that needs to happen so that those data can be trusted. Moving on, we also know that the volumes of transports can be reduced. This has been touched on already, so I'll just keep this very brief. I unfortunately don't have statistics for San Diego or Imperial County, nor for the state of California, but looking at data nationally, we know that 77% of ambulance transports are for low acuity patients. To be clear, that's not the same thing as saying unnecessary transports, right? Even some low acuity cases still require an ambulance. That said, there's certainly a fair amount of unnecessary volume embedded in that 77%, and if we can reduce that, we can go a long way to help with APOT. Now, the reason we talk about why the proportion of ambulance offloads that are perhaps unnecessary matters is because volume overall matters. What we're looking at here in that top blue line is the proportion of patient offloads handled in under 20 minutes. That green line is the deviation of offload volume against a 24-month moving average. So when that green line goes up, those are periods of high patient offloads via ambulance. And when that blue line goes down, those are periods where APOT times are particularly bad. Now, what we can see from here is that it's not a one-for-one relationship. However, the data are inversely correlated to a statistically significant degree. A lot of you might be asking, like, why am I showing this? Like, it feels plainly obvious that it's a function of volume. But I think it's important to show with data, and we do this for a couple reasons. One, this volume relationship is important to establish because volume coming to hospitals is something that they do not unilaterally control, right? These are things that are a little bit, in fact, a lot of it out of our control right now. And then the second point to make is that when we look at patient volume, it's important to realize that we can reduce it through various measures, and by making it tools that we can reduce, we can reduce it through various measures by making release valves. So when we look at this volume trend, we see that it's not a static problem, right? It ebbs and it flows. So what we need is not necessarily a static solution, but we need that release valve when the patient volumes flow. What are some of those release valves? Well, we talked about reducing offloads in that 77% that are unnecessary. We talked about reducing some of the leads from, we talked about reducing some of those patient offloads in that 77% volume. We also need to reduce behavioral health volume. So when we talk to hospital leaders, one of the things we hear consistently is that the sticking point, their most problematic patients to move through the system are these behavioral health patients. It stands to reason. We know from their length of stay that they spend in the hospital, their length of stay is longer because their care management is more difficult and their case management is more difficult. What this tells us is that if we can make meaningful improvements on behavioral health, we can relieve this sticking point, we're also going to go a long way to helping improve APOT because, as I said, this is one of the key release valves that we need to improve things when we flow. Another point to make is that this is not something that we face consistently with each LEMSA, right? So when we look at this graph here, what we see is that APOT volume matters dramatically depending on density for each LEMSA. The 11 LEMSAs with the lowest proportion of APOT volume, just that 5%, are also the ones with the best times in terms of getting patients handled in under 20 minutes. Those LEMSAs where we look at the highest density, those taking care of the overwhelming volume of patient transports, are also the ones where we have the most problems getting patients handled in under 20 minutes. This speaks to why it's a volume issue. This speaks to why it's a throughput issue. This also speaks to why one single 20-minute standard isn't going to be helpful and isn't appropriate in each of those LEMSAs. Each of those color codes is going to be a different story, and we need that offload time goal to be adjusted for each of those color codes. And then finally, we'd also mention another form of variation is that regional variation. What's happening in Santa Barbara is, of course, very different than what is happening in San Diego, and is very different than what's happening statewide when we look at those averages. So by comparing each of those regions, we see, again, that the 20 minutes needs to be adjusted, and we see that there's differences in each of those regions that need to be addressed locally. With that said, I'll pause and go back to the table and welcome any questions. Thank you.
A 1-minute summary, if I may. Thank you so much. Just a phenomenal compilation of so much here. If we boil this down a little bit, I kind of divide it into some more focused areas. We need first and foremost, we need good data. We need to understand what's in front of us and how we act on it tomorrow, next month, and next year. We've beat up the communication pathway extensively today. I think that's first and foremost. If we can't talk, we can't figure out how to move forward. We learned that in strong fashion through COVID. Secondarily, especially following Carmela's talk this morning, we need to understand that the hospital cannot shoulder the brunt of all we're in store for over the next one month, really. 1 month, 1 year, 5 years, 10 years. We need to consider every alternative we have to deliver health care for all the patients that we're going to see. I encourage everyone to take a quick look at the APOT toolkit that was so nicely aligned by CHA nearly a decade ago. It's still very pertinent with that. And in addition, some other pieces to consider briefly are within the EMS arena. There's a lot of pieces on the plate right now. We have community paramedicine. We have alternate destinations. We have treat and release protocols, which are allowed. We have telemedicine on the table. So many pieces that may decrement those patients coming to our EDs. Some of these pieces are not allowed in regulation. The answer there is we need to change regulation, right? There's way too much on the plate right now to continue down the path we're on. I encourage us all to take a hard look, all contribute, communicate, and figure out ways to move forward along all these paths, of which there's probably 100. But if we can boil them down into about 5 major categories, I think we can make progress. So, thanks for listening today. Thank you. Time for questions?
We'll have time for a couple of questions. I know we're running short, but obviously a lot packed in here, and would hate to miss the opportunity if there's some questions from the audience.
So some proportion of ED visits are people that walk in or are brought in by a family member. Can you tell how that's reflected or not reflected in the data and how that may impact throughput? Presumably some hospitals are more impacted by that than others.
Definitely. That's a great question. Overall, it's about 80% of folks walk in, and many of the walk-ins include the same sort of critical nature as our ambulance patients. That group overall is much more difficult to deal with. I mean, we have EMTALA. Once they've set foot on the hospital grounds, we're bound and obliged to take care of them. I think maybe the high-level answer to that is also entwined in the other population, which is let's see what we can do to improve our primary care, maybe alternate destination. Maybe, I mean, if we look at an extreme, can we change EMTALA law? I mean, we need to think outside the box in ways that we can affect that population, but that's a really tough population to divert in any way, shape, or form. Shortening hospital visits, referring to their primary care for, but they need to have a primary care. So, boy, I think that would be probably another hour talk, wouldn't it? Go ahead.
I have just a comment about that. I don't know of a place to get that information that's in some form that can be automated to collect. And I'm very sensitive for all the segments of when we're going through this collection to try to find places that the data is going to be meaningful, actionable, and is easily collected and manipulated, right? And so where my thought is right now, I have not come across a place where I can get that over total ED volume on a daily basis, right? We're using the COVID database to get pieces of information to help us in this analytic. We're contemplating at the moment asking hospitals to collect that data. And there are other data points the hospitals are asking us to collect. But I want it to be, as I said, meaningful, actionable, and somewhat easy to collect and manipulate. Those are kind of standard requirements, right? So we're going to try to get at that because I don't think the response and transport folks understand that they're only about 20% of the business, right? That 80% of the folks come in, and on any given day, those proportions change. And they have a real impact on hospitals' ability to effectively offload ambulances. And by the way, some of those offload people, as you read in the press, are gunshot victims or people that are, violent, they've suffered a trauma, and they get thrown out of the car, and you got to deal with them. And the person with a level 3 in the ambulance doesn't realize that there's a life-threatening or several life-threatening things going on at the ER at the same time the ambulance arrives. So your point is well taken.
Those folks do end up reflecting in a lot of the data points that we cover and follow, like APOT gets reflected by increased populations of patients coming in with respiratory illness, of which, we're about to see 2 or 3 months worth of. So that's going to be a huge play. We can keep an eye on the other data, which also I think gets impacted by those folks.
One more question over here, and we'll wrap up this panel with that question.
There was a data set that mentioned that 77% of EMS transports are low acuity. What sort of needs falls into low acuity?
So that was pulled from NEMSIS, and low acuity in those cases are defined as any case where the progression of illness is unlikely. I realize that's a very fuzzy definition, but that's the one that was provided. In looking at some of the conditions that actually fall into that, it was a lot of orthopedic cases, things that were non-systemic, things where there wasn't going to be a clinical cascade or escalation to something that's more life-threatening. It was your broken legs, your falls, those things of those varieties seem to comprise most of the low acuity, which, in some cases, if you fall and break your hip, you still need an ambulance transport. So that's not to say that's necessarily the same thing as unnecessary. But it's also someone who doesn't need life-saving care, and it's not necessarily that time is of the essence. And though that wasn't in the definition per se, I think that's a key element is time. Patients who could wait without getting sicker seem to be one of the common themes in the conditions that are included in that low acuity bucket as defined by NEMSIS.
So let's go ahead and give this panel a round of applause. I know we have lunch coming up shortly. I'm sure they'd be happy to take some more questions.